extremely important ones is GIT hormones and GIT motility, right? So I have given you a lot of variety of questions based on all these important topics, right? So I would be starting with the first question now, which is the chymotrypsinogen is activated into chymotrypsin by chymotrypsinogen is activated into chymotrypsin by, right? Who does this? The chymotrypsinogen is activated into chymotrypsin. So if I start with the chymotrypsinogen is activated into chymotrypsin by, remember it's a very important question. There are two questions here. First, let us do what I'm asking you here. So chymotrypsinogen is activated into chymotrypsin by. Yes. What should be the answer? The answer is none other than trypsin. So who does that? The answer is trypsin, right? Remember that trypsin converts chymotrypsinogen into chymotrypsin. It also converts pro-carboxypeptidases into carboxypeptidases. It also converts pro-carboxypeptidases into carboxypeptidases and pro-elastase into elastase, right? So trypsin does many of these reactions. Another important question which immediately should strike you is that, you know, what is this type of feedback? Is it positive, negative, or feed forward control? So remember, very important question for the exam. This is an example of positive feedback. Remember the mnemonic I have told you in the lectures, claps, right? So just go through the claps. What is clap? Calcium induced calcium release, clotting, LH surge, lactation, action potential, activation of pancreatic pro-enzymes to their main form, which I'm discussing right now. And finally, a very important one, which is decompensated shock, right? Moving on to question number 2. All of the following are true about the BER. What is BER? Very important topic for your exam. Basal electrical rhythm. So all of the following are true about the BER. Let's see this. Tone of contraction is related to the amplitude of the stimulus, right? So have a look here. There are 3 spikes. The height of contraction is more, right? Then there is only 1 spike. The height of contraction amplitude is less. Then there are again 3 spikes. The amplitude is again more. So what is happening? More is the frequency of the spike potential. More is the tone of contraction. So tone of contraction is related to frequency of stimulation. Please remember, it is not related to amplitude. It is not, we say, right? So this is wrong. Frequency of contraction is permanent. This is also true. And threshold of contraction is minus 20 millivolt. What does that mean? Please look over here. If the basal electrical rhythm recording is going on like this, right? Remember, what is BER? The rhythmic oscillations in the activity of sodium potassium ATPase pump. This is minus 65 millivolt, which is your RMP. This is minus 45 millivolt, which is your firing level, right? What is minus 45? Firing level. Remember, also known as threshold potential. So that means, what is the threshold of contraction? Yes, minus 65. I want to go to minus 45. How much do I need? Plus 20, right? So threshold of contraction is around the minus 20 millivolt, or we need a stimulus of plus 20, as we say, right? So coming back here now, as soon as I reach the firing level, remember, I will have this kind of the spike potential, this kind of spike, right? In this spike potential, which is the true action potential, if you look carefully, there is a depolarization phase and there is a repolarization phase. The depolarization is due to, remember this important MCQ, calcium influx, and the repolarization, like always, is due to potassium efflux. So you have to know both for me, very important, right? So let's go back to the answer. All of the following are true about BER. Remember, this is true, this is true, this is true. That means what is false? The answer is actually A, right? So tone of contraction is not related to amplitude, it is related to frequency, right? What things can increase the frequency of these spike potentials? Remember, as I've shown you, 3 here, only 1 here. So who can increase the frequency of the spike potential? Vagus or sympathetic? Yes, what should be the answer? Vagus or sympathetic? Remember, vagal stimulation. Vagal or sympathetic? Anjali Jorwal, I have already explained you BER. Basal electrical rhythm is the rhythmic recording of the electrical activity of the single unit smooth muscle of the gastrointestinal tract. And Anjali Jorwal, you sir, right? I am not your friend, right? So have some manners. You sir, right? Explain BER, sir, right? So, and I have already taught you this in our videos. So kindly go and have a look at the videos, right? All are actions of cholecystokinin except. All are actions of cholecystokinin except. That means what does the cholecystokinin does not do, right? For basal electrical rhythm, it is just the recording of electrical activity of the gastrointestinal tract. Who are the pacemaker cells of GIT? Interstitial cells of Cajal, right? These are the pacemaker cells of GIT. Yes, what is not an action of cholecystokinin? Cholecystokinin increases the pancreatic secretion. Yes, it mainly increases the secretion of enzyme-rich juice. Remember, this is a discussion of the important MCQs. Anjali Jorwal, right? So we are not explaining you the entire topics here. For this, you will have to watch the video lectures. Cholecystokinin causes the gallbladder contraction. Yes, independent MCQ. This is known as cholegog action. Cholegogs mean the substances which increase the contraction of gallbladder and thereby release bile. Recent articles also tell us that cholecystokinin relaxes lower esophageal sphincter. So this was a difficult one because cholecystokinin actually decreases the gastric emptying, and it decreases the gastric emptying, thereby decreases the gastric secretions. So basically this is a difficult one in the sense you might get confused about the lower esophageal sphincter, but please remember it actually decreases the gastric emptying, right? So it decreases the gastric secretion. Yes, by finder I can see that you have given the correct answer. So the answer should be it will not increase but decrease the gastric emptying. Remember, what is gastric emptying? Whenever we have the food in the intestine or the duodenum, I would delay the gastric emptying because already I have a lot of food in the duodenum. Who does that? Presence of fats, carbohydrates, acidic chyme, and various GI hormones such as cholecystokinin, right? And then secretin, GIP, GLP, right? These all. Moving on to question number 4. Water is absorbed in the jejunum, ileum, very important question, colon, and excreted in the feces. Arrange them in the order of the amount of water absorbed or excreted from the greatest to smallest. From the greatest to smallest. What should be the order? Greatest to smallest. Yes. Remember, generally we say that the water has two sources. Either it is coming from your GIT secretions or it is coming from ingestion. Ingestion means how much water you are drinking in a day. It could be 1 to 2 liters. Generally we all drink at least, around 1 to 2 liters. Total, it gives my GI tract an exposure of around 9 liters of water. Out of this, there are 3 places where I reabsorb water. Jejunum, Aurora, that is wrong answer. So please now focus. Ileum, colon, and feces. So out of 9 liter or 9,000 ml, we are absorbing in the jejunum 5,500 ml. In the ileum, another 2000 ml. In the colon, another 1300 ml. If you add these for me, you will easily get the answer. This all will be around 8800 ml. That means in the feces, only 200 ml is excreted. So what should be the order? Jejunum, ileum, colon and feces. Very, very important question. Must know, must. And I can see that a lot of you have given me actually the wrong answer. So this makes this question very important, right? So water is absorbed maximum where? That is another important MCQ, jejunum, right? Jejunum is, remember, the main site where a lot of nutrients and water is absorbed. Which of the following is the most alkaline? Another very interesting question. Small sec education, you are in which year? That it depends. If you don't want to study physiology, what to say? Okay, if you don't want to study, then what can I comment? But in INI-CT, we are seeing 15 to 20 questions from physiology every 6 months. And in NEET PG, we see around 8 to 10 questions every year, right? Now it is your own discretion whether you want to study or not, right? So which of the following is the most alkaline? So if in the first year you want me to say that you should not study physiology, then what to say, right? So maybe you can directly start reading medicine if you can understand it, right? So which of the following is the most alkaline? Remember, these are basic sciences. If you don't know anatomy, physiology, biochemistry, you will not be able to understand. Yes, Dr. Smolsek education, I have given your answer, right? For PG preparation, 15 to 20 questions are coming in INI-CT. 7 to 8 to 10 questions in NEET PG, right? Which of the following is the most alkaline? Somebody has given me the answer, pancreas, aurora, but please see, that is why I have given this question here. It is actually the Brunner's gland. Brunner's gland is present, anatomy now, second part of duodenum. Brunner's gland is present in the second part of duodenum. You will be learning in anatomy again. It secretes a highly alkaline fluid having a pH up to 9.3. Please remember that. If this option is not given, then pancreas will be my answer. The reason is the pH of the pancreatic secretion is up to 8.8, right? So what is the better answer? Brunner's gland. That is why I gave you this question, right? The PEP-T1 mechanism, question number 6, another important one. The PEP-T1 mechanism for the absorption of di and tripeptides requires which of the following? Interesting mechanism for peptides. Remember, if this is the luminal side of your intestinal epithelial cell, see this carefully now, and this is, let's say, the basolateral side. Now what I can gather is, first, just a revision. So this is an intestinal epithelial cell. This is the basolateral side, and like always, this is the luminal side. The basolateral side is towards the blood vessel. Towards the blood vessel, we have the sodium-potassium ATPase pump. We have the sodium-potassium ATPase pump. So what happens here is, the sodium goes out and 2 potassium comes in. Just see this carefully now. Sodium goes out and 2 potassium comes in. This most of you will be knowing by now. And now from the other side, first I am doing another question. Sodium comes in, and double A is always amino acids. But I am asking you here peptides. So answer has to be different. So just see this. Now from the other side, the hydrogen ion is the ion which is required for peptides. And the name of this transporter is peptide or peptidyl transporter 1. peptidyl transporter 1. Once the peptides come in, they will be broken down into the amino acids which came in, right? And the amino acids will be going into the blood vessel via their own transporters, which is just like the glucose transporters known as amino acid transporters, right? So very important mechanism. So which ion is required? Now I think all of you will be able to tell me hydrogen, but for require, if I ask you the question which ion is required for amino acids, then don't say hydrogen, then the answer would be sodium. That means if I ask you which ion is required for the absorption of glutamine, right, histidine, serine, answer is always sodium. Moving on to question number 7 now. So shown below is the membrane potential and the spike potential in the GI tract. This is again a very interesting question and difficult one as well. So second graph associated shows changes in the muscle tension. Increase in the muscle tension is due to all of the following except, please see the question, let me zoom the figure for you. What we are seeing is that the tension of the gastrointestinal recording is increasing. So who causes increase in the tension, right? So which things are stimulatory in the GIT? That is the question, right? So which ones all increase the tension? Does the acetylcholine do? Yes. That is, remember, excitatory. Stretch, yes. How? Stretch causes opening of stretch, yes Aurora, that is correct answer, good. Stretch causes opening of stretch sensitive, also known by the term mechanosensitive calcium channels. Mechanosensitive calcium channels. So stretch is going to increase, that is true. Parasympathetic stimulation already is excitatory. So the answer is adrenaline or sympathetic stimulation, which inhibits or decreases the tone, right? So which are the excitatory ones which stimulate the GI motility or GI secretions or GI blood flow? Vagal stimulation, acetylcholine and stretch. Remember 3. In the question number 8, we have shown you, this is a very good question again. Figure is given in all the standard books, Indian authors, foreign authors. Given in the diagram are the movements of the GI tract occurring at regular intervals during fasting and completely inhibited by a meal. These are which contractions? These are which contractions? So what we say here is, when I look at this figure, remember these contractions are occur in the fasting state and they are completely inhibited by a meal. So let's zoom this picture. Let's see, is it peristalsis? No. Peristalsis, remember, is the forward propulsive movement of the food. The bolus is moving forwards from oral to caudal direction and it occurs after having a meal, right? So peristalsis is not the correct answer. Segmentation contractions, remember, are ring-like contractions in the small intestine which happens like this. These are ring-like contractions in the small intestine which move the chyme to and fro. So your chyme will move like this. What is the advantage of moving the chyme to and fro? It will facilitate absorption. It increases the GIT absorption. It increases the GIT absorption. So this is also going to occur after having meals. Peristalsis, remember, forward propulsive movement of the bolus, forward propulsive movement of the bolus. This peristalsis, segmentation contractions, mass action contractions. What is mass action? Mass action means large number of intestinal segments contract together, right? Especially in the middle of transverse colon. Large number of segments contract together. When the large number of segments contract together, remember they can push the bolus, as far as rectum. So as then we say, name has the answer. Just listen again. As the large number of segments contract together, they push the bolus as far as rectum. So this is commonly occurring in the middle of the transverse colon. So contractions number A, B and C, which is written in the figure, they all occur in well-fed state. So A, B, C, they all occur in well-fed state. That means after having meals. But the MMC is the answer here. Migratory motor complexes is a very important short note for your exam. You have to remember each and everything here. Remember, these are ring-like contractions. So please go through the video. I have told you all the important points. The MMCs is due to the hormone Motility. Very, very important MCQ, right? Then Motility is released from which cells? MO cells present in the stomach, duodenum and jejunum, proximal colon. Then remember, migratory motor complexes are seen in fasting state, in between meals. Ring-like contractions occur from the body of the stomach to the terminal ileum. And what happens is standard duration of MMC, that is also asked in exam. 90 minutes is the standard duration of MMC, 90 minutes. Coming back here, what are you seeing? Let me zoom the picture, just see this carefully. Out of 90 minutes, the phase 1 is actually having a duration of 80 minutes. This is the silent phase. Silent means no contractions occur here. Phase 2 देखिए, phase 2 is 6 to 7 minutes. 6 to 7 minutes means irregular contractions occur in 6 to 7 minutes. This is phase 2. Then please look at phase 3. Phase 3 is the only one which is regular contractions occur. So please remember, you have to know phase 1, 2, 3, which phase is silent, which phase is, having how much duration. What is the purpose? Let's recall. In the phases 2 and 3, remember, 1 to silent hai, silent mein nothing will happen. In the phases 2 and 3, there is more and more secretion of the gastric juices, bile, duodenal secretions, intestinal secretions. So what will happen is the food will move from the stomach to the duodenum to the jejunum to the colon at the rate of, another very important MCQ, what is the rate of MMC? Take this, they ask very, very commonly. 5 centimeter per minute. Must know again. So जब भी आपका fasting state होगा, whenever the MMC will occur, for 80 minutes you will not come to know anything, but for 10 minutes you will have irregular contractions. So your food will move from the stomach to the duodenum to the jejunum to the ileum at the rate of 5 centimeter per minute. What will happen eventually? Eventually these 2 and 3 phases contractions are known as housekeepers. Who are housekeepers? Who will come to your house and clean your house. So these are known as housekeeping contractions or housekeepers of the GIT. Housekeepers means they clean the gut. When I say they clean the gut, that means they are pushing the food forwards. So my stomach eventually will become empty. Now remember, when the phases 2 and 3 will occur, there is no food. So now you will start having, due to MMCs, which contractions? Hunger contractions, right? So everything I have revised with you, but this is to be known in lot of detail as discussed in the videos, right? Must know. Moving on to the next one here, which is our question number 9. So a 65-year-old man presents with acute onset of, this is related to the clinical side now, so abdominal pain, and CT scan shows a diagnosis of pancreatitis, which is acute pancreatitis, inflammation of the pancreas. Actually, I'm asking you that which of the following activates trypsin in normal digestion, right? So basically there is inappropriate activation of trypsinogen to trypsin. So who does that? Yes, any guesses? Who will cause the conversion of trypsinogen to trypsin? Please remember the answer is enterokinase. Enterokinase is released from the duodenum, which causes conversion of trypsinogen to trypsin. It's a very, very important MCQ. It definitely can come in your prof exam, and it is a very, commonly asked question. So enterokinase converts trypsinogen to trypsin. I have also given you another question of the enterokinase that I will discuss later. Moving to question number 10, another clinical related question. A researcher is studying the mechanism by which the gastrointestinal system coordinates the process of food digestion. Specifically, she is interested in how distension of the lower esophagus by a bolus of food changes the responses in the downstream segments of digestive system. She observes that there is a resulting relaxation and opening of the lower esophageal sphincter after the introduction of the bolus. Which of the following substances is most likely involved in the process being observed here? Another very, very important topic, This is what is happening here is actually peristalsis. This is none but peristalsis. So in the peristalsis, what actually happens is, if this is your intestinal segment and this is, let's say, a bolus. So as the bolus stretches the intestine, as the bolus causes stretches the intestine. So as the bolus stretches the intestinal segment, right? Intestinal segment. Immediately what we observe is that there is Shah plays Aurora. No, B is not the answer. That is why I am discussing the mechanism of peristalsis for you all. No. Motility is the wrong answer. Motility to abhi bataya hai. Motility is responsible for MMC. So it can't be motility. That is wrong answer. So please listen carefully. As the serotonin is released, it causes increased stimulation of sensory nerves. So more sensory nerves are stimulated. These go and then excite my very, very important plexus known as myenteric plexus. Please see the mechanism, very important. This you have to write in the exam. If I ask you a question about peristalsis, it comes as a 5 mark or 3 mark question. Once the myenteric plexus is stimulated, please see what is going to happen now. There is a part which is known as behind the bolus. In this part, which is anterograde, you know from anatomy, there would be contraction. So please look at this. This part is contracting, anterograde part. But in the part which is ahead of the bolus, that means retrograde. So what we observe is, in the part which is behind the bolus, sorry, I think I just spoke the other thing, so I'll just correct it. So in the part which is behind the bolus, there is going to be retrograde contraction, right? So this part which I'm showing you over here, there would be contraction. This retrograde contraction occurs due to, very important question, acetylcholine and the substance P. ठीक है, दोनों both are important. They can ask you anyone. Retrograde part is contracting, but please look at the anterograde part. In the anterograde part, that means which is ahead of the bolus, there would be relaxation. So in the anterograde part, there is relaxation. How will the relaxation occur? That was the question, due to nitric oxide and VIP. Now please see the complete thing. This part is relaxing. Part behind, retrograde, is contracting. Naturally, the bolus will move forwards like this. This is the direction of the movement of the bolus, is from mouth to anus, which is known as oral to caudal direction, right? So can you now tell me the answer? What should be the answer? Which neurotransmitter is responsible for the relaxation? Yes, that means anterograde relaxation. क्या आंसर होना चाहिए? Motility तो गलत हो गया. Motility is MMCs. Neuropeptide Y and VIP has the neuropeptide Y and secretin has no role. So the answer is none other than VIP, right? So it's I will not say difficult, but you have to know the exact mechanism of peristalsis, which I have just told you. Please remember, peristalsis does not require a spinal cord. Even if I cut the spinal cord of the animal, then also the peristalsis will occur. Why? Because peristalsis occurs due to distension of the intestinal segment, right? Distension of the intestinal segment. It is a localized distension of intestine. Yes, absolutely correct. Everyone is correct now. Another important MCQ, which of the following is known as the physiological beta cell stimulating hormone of GI tract? So important question. Remember, it is none other than GLP-1. GLP-1 stands for glucagon like peptide. Shah, please, what explanation? Yes, Shah, what explanation you want? Already I have repeated once. Yes, what do you want me to repeat? Whenever there is distension of the intestinal segment, the serotonin is released. This serotonin stimulates the sensory nerves. Okay, I'm doing it. Please listen once more. The sensory nerves stimulate the myenteric plexus. Now in the part which is behind the bolus, there will be retrograde contraction due to acetylcholine and substance P. The part which is ahead of the bolus, it will relax due to nitric oxide and VIP. So what will happen? The bolus will move forwards from mouth to anus, which is known as oral to caudal direction, right? Yes, Shah, please. Is it fine now? Okay, let's move on to the question. So glucagon like peptide which is released from L cells present in the proximal intestine. This causes stimulation of the pancreatic beta cells, thereby causing increased release of insulin, right? So please remember, GIP also they can ask you in the exam. This is the new name of GIP is glucose dependent insulinotropic peptide. Glucose dependent insulinotropic peptide. It is produced from the K cells, which are also present in the proximal intestine. And remember, GIP also stimulates the pancreatic beta cells to release insulin. Both of them belong to a family of hormones known as incretins. Must know. So because glucagon like peptide was discovered earlier, so they named it as physiological beta stimulating hormone of GIT, right? Somatostatin actually, inhibits the insulin release, and ghrelin is a hormone which basically makes you eat more. It is responsible for obesity, right? So ghrelin is also going to decrease the insulin release. Moving on to question number 12. Yes, absolutely correct, Dharmaraj Mehta. Cyclic AMP is the second messenger for the action of which of the following on the parietal cell. Now this is related to second messenger system. You also do it in biochemistry. So you should be able to recall for me. Otherwise, please remember acetylcholine when it acts via M3 receptors and gastrin when it acts via CCKB. This is an independent MCQ for the exam. What are the name of the receptors for gastrin on the parietal cells? This is an independent MCQ, that is why I have given you here. Second messenger for acetylcholine is IP3, inositol triphosphate and diacylglycerol. This is in biochemistry called as 2C, second messenger system. Again, same answer, IP3 and DAG. This again in biochemistry we very well understand, 2C. And then somatostatin via somatostatin receptors is also IP3, which is again 2C. The only one which is using cyclic AMP is histamine via H2 receptors, which causes increase in cyclic AMP, which is famously called as the system 2A, right? 2A. So important question regarding the neurohumoral mediators. These are famously known as neurohumoral mediators of acid secretion. So in today's time you have to know these ones, that which of the following cause the acid secretion and with the help of which second messengers, right? So important question. 13.1 was a 50-year-old patient with a past history of cirrhosis. Cirrhosis, remember, liver damage due to excessive drinking of alcohol or hepatitis, other causes you will be learning in your medical career progression as you go to second prof. So cirrhosis undergoes a total colectomy. Colectomy means removal of the colon. So removal of the colon would be expected to cause which of the following? This I would consider as a difficult question. So this probably, I can say on the analysis of difficulty level that this is a hard question. This is a difficult one. Yes, what will happen if I remove the colon? Remember, in the colon, you have the colonic bacteria. You have the colonic bacteria. One of the functions of the colonic bacteria is to convert ammonia to ammonium ion. Ammonia to ammonium ion. This is one of the functions of the colonic bacteria. So colonic bacteria do this. Naturally, if you remove the colon, then what will happen? Ammonia will not be converted to ammonium. Yes, absolutely correct, Aurora. That is, bacterial flora will be absent and colonic bacteria will not be able to do this. So naturally, what should be the answer? If you know this fact, you could have easily given me the answer. Increase in blood ammonia. Remember, colonic bacteria also act on dietary fibers to produce short chain fatty acids. That question also we will discuss just in a while. Moving on to question number 14. Surgical resection, again an interesting, a difficult one I would say, tough question, next one also. Surgical resection of the terminal ileum is most likely to result in which of the following? Remember, terminal ileum is one of the major places where B12 is absorbed, right? So B12 absorption occurs in terminal ileum. But when you look at the option, you will be surprised that option I have not given you, right? So what should be the answer? Another interesting fact about the ileum is, in the terminal ileum, this should be known to you all, again related to biochemistry and physiology both, 90% of the bile salt absorption occurs in the terminal ileum. 90% of the bile salt absorption occurs in the terminal ileum. Now can you guess the answer? Remember, if I remove the terminal ileum, I cut it out, then what will happen? I will not be able to absorb the bile salts. If I am not able to absorb the bile salts, I will not be able to, yes, absorb the fats, fatty acids. So now lots of fatty content, lots of fat and fatty acids will be in my feces, and fats will draw lots and lots of water by osmosis. So what will happen? There will be increase in water content. This causes increased fat in the fecal content. More fats in the fecal content means increase in water content. Increase water content of the feces, right? So that is why it was a tricky question and required your knowledge of 90% of the bile salt absorption occurs in terminal ileum. Moving to the 15th one, in infants, again a very expected question. It has been asked multiple times in the exam. It's a multiple repeat. In the infants, defecation often follows a meal. That means as the small children, they eat food, the infants and the neonates, immediately they will have defecation. So defecation occurs immediately following a meal. So what is the cause of these colonic contractions? So the answer actually here is not related to any hormones, but actually the answer is gastrocolic reflex. What is the meaning of gastrocolic? Gastro, remember GIT reflexes are very beautifully named. Gastrocolic. Stimulus is distension of the stomach, colic contraction of the colon. So this is famously called as gastrocolic. What is enterogastric? I just told you a while back. Entero. Stimulus is distension of the duodenum. Gastric is distension of the duodenum is the stimulus. Gastric is decrease in gastric emptying. That means whenever you have lot of food in the duodenum, naturally you will not push more food from the stomach into duodenum. That means you will decrease the gastric emptying because already I am having lot of food in the duodenum. That is distension of duodenum, right? Another very important. Yes, Kishore Hegde, absolutely correct. Gastrocolic was the answer. Moving to question number 16. This is a repeat for some of you who might have missed earlier. That question was a clinical problem. This is a straight away physiology question. No integration with clinical. Now simple thing. After secretion of trypsinogen into duodenum, the enzyme is converted into trypsin by which of the following, right? So now the answer is enteropeptidase. Remember, enteropeptidase is same as enterokinase. It is same as enterokinase. So already we have discussed that. 17th one, secretion of which of the following substances is inhibited by low pH? Another expected question for the exam. Which of the following substances is inhibited by low pH? Yes, sharply, that is right. Secretion of which of the following substances is inhibited by low pH? That means acidity. What should be the answer? Think about it. Yes, inhibited by low pH. Yes, tricky one? No, it is easy one actually. Just think about it. Remember, there is one hormone only out of these, which is gastrin, which stimulates your parietal cells to increase HCl secretion, right? This gastrin secretion is under a negative feedback. That means whenever now the gastrin stimulates parietal cells to increase the HCl secretion, right, whenever there is increase in acid or low pH, what will happen? They will immediately now inhibit the gastrin release. Why? Because already there is lot of acidity. So gastrin is under a control of negative feedback. Remember chapter 1, what is negative feedback? If something is increasing, I will like to reduce it. Acid is increasing, so who increases acid? Gastrin. I reduce gastrin. If acid is decreasing, I will increase gastrin. So reversal of the stimulus. Secretin. What does secretin do? Is the secretin inhibited by low pH? No. Please remember, very important question. Acidic chyme is one of the very important stimulus for secretin release. Acidic chyme is rather most potent stimulus for the secretin release. Please remember that. Another important question. Gastric inhibitory peptide will decrease the gastric secretion, acid secretion. VIP also decreases the gastric emptying. So now we move to question number 18. This I think most of you should be able to tell me now. Yes, this is again a repeat from the PG exams. The MMC is triggered by which of the following? That means migratory motor complex is due to which of the following hormone? No doubts about it now. Motility. Remember, motility is released from MO cells, which are further present in 3 places: stomach, proximal colon, and duodenum and jejunum. Duodenum and jejunum. Remember, they are maximum in duodenum jejunum junction. Already discussed, motility is responsible for MMCs, migratory motor complexes, right? Yes, absolutely correct. Moving to 19th one. Very important question again a repeat from the INICT. Maximum frequency of BER is in which of the following segments of the gastrointestinal tract? Yes, anyone knows the answer? Maximum frequency of basal electrical rhythm is where? Normal values, remember, stomach, it occurs around 4 times in a minute, 4 per minute. The answer is actually duodenum, where it is maximum 12 per minute, right? Jejunum, it is around 8, we say 8 to 10 rather, but 8 is the good answer. And cecum, again you have to remember for me, because it is minimum, only 2 per minute, right? So answer here was duodenum. Must know who has the minimum, who has the maximum. Must know duodenum maximum, cecum minimum, right? There is sigmoid also. In sigmoid it is 6 per minute. In some books sigmoid is given as the answer for the minimum. That is absolutely wrong, right? So please remember duodenum and cecum if you don't want to remember the other ones. This purposefully I have given a question from chapter 1, which is integrating with GIT. This is again a favorite question. It has come in NEET exam many times. Transport of glucose from the intestinal lumen into intestinal epithelial cell is an example of which of the following? Think about it. This is the intestinal epithelial cell. This is the basolateral side, right? So think about it. This is the basolateral side towards the blood vessel. Yes, I'm waiting for your response. What should be the answer? This is the basolateral side towards the blood vessel. Please remember, over here we have the sodium potassium ATPase pump, like always. Nothing new here. So we all have a good idea here. Sodium decreases, but please look at over other side. Sodium comes in along with glucose. What is the name of this transporter? Yes, anyone? Very important question. SGLT1, sodium glucose linked transporter 1. This is an example of secondary active transport. Remember, this is also the principle behind ORS, oral rehydration solution. Remember, if the you are having diarrhea, then the doctor will advise you to take salt sugar mixture. So oral rehydration solution, what is the principle behind giving a salt sugar mixture? Because please remember, as the sodium will come in, it will bring the glucose along with it, right? That means sodium is facilitating the absorption of the glucose, right? So many MCQs. That is why I have given you this question. Please have a look. Secondary active, SGLT1, principle behind ORS, right? So any question can come in the exam. Facilitated diffusion is the wrong answer, Kishore Hekde. I ask you from intestinal lumen. This is intestinal lumen. Facilitated diffusion will be the answer. Okay, please listen. When will the facilitated diffusion be the answer? If I ask you, how will the glucose move from the basolateral side to the blood vessel? Now the answer is this transporter, which is GLUT2. This is facilitated, right? So answer over here is secondary active. Let's move to 21. SCFA. I think I discussed that. What is SCFA? Yes, can you recap for me? Short chain fatty acids. Yes, absolutely correct, Aurora. Short chain fatty acids. Short chain fatty acids, remember, they are produced by the action of colonic bacteria on the dietary fibers. Remember, cellulose, hemicellulose, I can't digest, right? So that is why I have to break them down by the colonic bacteria. There are various types, but please remember acetoacetate, propionate, and butyrate. The maximum in the number are acetoacetates, concentration 60%, and propionate is 25%. This can also be asked. So answer is actually colon. You are absolutely correct. Most of you. That's good. Likhita, yes, correct. Right answer. Moving to 22. This is again a slightly difficult one, as I might say. Gastric pressures seldom rise above the levels that breach the lower esophageal sphincter even when the stomach is filled with a meal, due to which of the following processes? That means if this is your esophagus and this is, let's say, stomach. So we are saying that even when the stomach is filled with a meal, the pressure in the stomach will never breach this lower esophageal sphincter. That means it will not happen that the food will start going in the reverse direction, back from the stomach into my esophagus. That doesn't happen. Why is that so? Because when the food is there in the stomach, lots of food, remember what happens is the fundus and the upper part of the body of the stomach, it relaxes. The fundus and the upper part of the body of the stomach relaxes. This is known as receptive relaxation. And if the fundus and the upper part of the body of the stomach relaxes, naturally what will happen? The pressure will always remain low. So this is known as receptive relaxation. Very interesting question if I relate it to chapter 1. This is which type of feedback? Yes, please brush it up, your knowledge from chapter 1. This is feed forward control. What is feed forward control? Anticipatory control. Remember, the bolus is in the esophagus, the food is in the esophagus, but I have relaxed the fundus and the upper part of the body of the stomach so that food can easily enter without any obstruction, right? This is a very important question from chapter 1, feed forward control as well, journal Physiology. Yes, Kishore and Likhita, very good, absolutely correct answer. Moving to 23, another very important question. With respect to plasma, saliva is which of the following? Always isotonic, always hypotonic, always hypertonic, or depends, can be hypo or hyper, depends on the whether gland is stimulated or not. Remember, the answer is actually always hypotonic. Let's see this why. So I'm quickly revising with you all. This is the acinus of the salivary gland. This is the ductal cells. So these are the acinar cells. This is my acinus, right? So this is a representation of the acinus. So these are the representation of my acinus. So what happens is, interesting question. The primary secretion, remember, is always isotonic. But as the saliva moves into these ductal cells, this is the representation of the ductal cells. These are your ducts. What happens now is I reabsorb sodium and chloride. So sodium and chloride are reabsorbed much more than potassium and bicarbonate secretion. Please see this. So I am reabsorbing sodium and chloride, but I am pushing the potassium and bicarbonate. Naturally, you will think that if sodium is being reabsorbed, then water should also be reabsorbed. But the problem is that the ducts are impermeable to water. The ducts are impermeable to the water. So can you tell me now why will it be hypotonic? Because remember, more and more sodium you have reabsorbed, but the water cannot come or behind sodium. The water can't follow. Why? Because the ducts are impermeable to water. So please remember, final status is always hypotonic. Very, very important question in physiology, right? Must know. Moving to the last few, 24. This is an easy one, but this exact question came in NEET PG exam. So let me ask all of you, what should be the answer? Gastric lipase is secreted by which of the following? Oxyntic cells, parietal cells, chief cells, or ECL cells. What is ECF? Enterochromaffin-like neuroendocrine cell. What should be the answer? Remember, the answer would be chief cell. Please remember that. Chief cell